thank you. Thanks to all of you for being here, and I really want to thank AI Innovation Sweden for the invitation to come here. It's really exciting to be able to be here today, and we're really excited about all the work that you're doing, and eager to share with you the results of our work together. So I think you've already heard about who we are, and so we'll just maybe jump right into the to what we're going to talk about here. You know, as Anna said, we wanted to talk with you about some of the efforts that we've been involved in for the last, well, really more than 3 years, probably more like 5 years, working together, trying to figure out how we can use data better in healthcare to try to solve many of the challenging problems that we face. And so, Markus, I'll let you talk a little bit more about Halland.
Sure, thanks. Thanks for the invitation. I represent today a region that is actually starting just south of Mölndal, so it's very close to here. Halland, we have a population of 330,000 people, and we have 3 hospitals and a number of primary care units. We have a pretty complete healthcare system, which is an important message going forward in this presentation. And we have emergency care, outpatient care, inpatient care, and all the components of a healthcare system that you want to drive together forward in order to deliver care for the future demand. And we've been lucky enough to get very good overall results. So what we know is that we're delivering high quality care at a very low cost per inhabitant. So we're in a good place. If you're even living in Halland, you have a good future statistically, because you live a bit longer than others in Sweden, and you are part of a efficient healthcare system. And that's not my view, because I'm deeply biased, obviously. But that's the view of the latest report from Vårdanalys, where they focus a bit, they change focus from productivity to efficiency. And having said that, you find Halland at the right top, which is a good place to be, where they say that the productivity is high and the quality is high at the same time. And they even put this regression line, the green line in the middle, saying that higher productivity is associated with higher quality, which is not obvious if you don't do the maths. But that's where we are. So we're in a pretty good place at the moment. And what we've been working on over the past 4 or 5 years together with the Harvard and Brigham team is not the complete picture, because we have also had great help from the local university in Halmstad, which has a very good unit working also on vehicles, by the way, called Center for Applied Intelligent System Research, CASER, where they have the skills that we in the regional healthcare systems usually don't have. So the combination of skills has been fruitful and producing, together with the Boston team, the results and novelties that I hope you will appreciate over the next hour or so.
So wanted to just say a little bit more about the organization that I work inside of and that our team works inside of. So you know, as you heard, I work at Brigham and Women's Hospital, which is one of 2 academic medical centers in Boston that are part of a larger organization called Partners Healthcare. And we describe Partners Healthcare is what we would describe as an integrated health system. And what that kind of roughly translates into is, I think, in some ways kind of analogous to a region here in Sweden, in the sense that within our system, we have all of the different components of care delivery that meet essentially all or most of the needs of the population of patients that we serve. So all of the hospital care, all of the outpatient specialty care, all of the primary care, emergency department care, and even the home care services. So all of those services and functionality are under one organization, which serves a population of about 6 million people in Massachusetts and the northeastern part of the United States. And I think the reason I'm mentioning this, I think, is because it in some ways, I think, is speaks to some of the similarities I think that we see in each other's organizations, and I think is part of the basis for why our collaboration has made a certain amount of sense. Our hospital is also very active in a variety of different types of research. We have sort of an umbrella organization called Brigham Research Institute that encompasses a whole number of different disease-focused entities, as well as some sort of cross-platform programs, and has been, and Brigham is sort of routinely one of the larger recipients of national funding from the NIH around research. And like Region Halland, we're also a high-performing organization, healthcare delivery organization in the U.S. And both in the areas of quality and patient safety, but also in innovation. And the question has come up at times of why is it interesting for us to work an organization in the U.S. to work with a healthcare organization in Sweden, and for me, I think the answer is obvious, and there's many reasons actually. I think we're both representing healthcare delivery organizations, and are both high-performing organizations in our systems, and are very interested in innovation and trying to figure out new ways of trying to improve how we can deliver care together. I think the other thing, and we're going to talk about this a little bit more, is that we all face very similar challenges in terms of demographics and rising cost of care, and also to a certain extent with fragmentation in care delivery. And but I think in particular, why Sweden? And I think from our perspective, the way that healthcare data is gathered and organized here is very advantageous in the sense that all of the individual data elements are registered around an individual person's social security number. That creates the possibility, at least, for being able to link all of that together, even though in its native form that isn't always the case, and there's sort of varying degrees of linkage. But there's also a lot less fragmentation in the care delivery system here, whereas you have a single regional organization that delivers all of the care for one population segment. That decreased amount of fragmentation in the system is really powerful from the perspective of wanting to be able to do population health research and to look at how and really to be able to look at all of that data together. And I think lastly, the fact that Region Halland is a relatively small organization, relatively less bureaucratic, has made it a really wonderful and agile collaboration partner to be able to do innovation work with. So I think that speaking from the U.S. perspective, it's really exciting to be able to have the opportunity to collaborate with colleagues here in Sweden. So what we want to talk about now is a little bit of the problems that we're trying to solve in being able to to sort of try to help you orient to our perspective in terms of the things that have brought us together and that we're trying to navigate. And mentioned those a little bit, but I want to talk a little bit about demographic trends and cost, about complexity and fragmentation, and last but certainly not least, the legal and regulatory environment. So, for those of us who work in healthcare, we're all very aware of the the very high expectations that the public has on what we do. And I think this is not limited to the US and Sweden. I think it's pretty generally true that, you know, societies are, you know, expect and increasingly want to have better outcomes. They want lower cost for healthcare. But there's always, you know, new technology and new diagnostics and treatments that are coming out, and everybody wants to be able to enjoy those. People want to have easy, convenient access to care when they need it. And I think there's also an important concern, you know, at the societal level of about having equity and equal access for all. And so all of these challenges are things that we're, you know, we feel that, and our system leaders and decision makers, they feel those challenges. We need to improve the healthcare system. We need to try to make it better. And the question is really how. But in the face of that, those demands of wanting to have it all really in healthcare, there's a number of factors about the changing demographics, and I think that you're probably all aware of these. These pyramid diagrams reflect the changing, the aging of the population essentially. If we, you know, looking 50 years back and 50 years forward compared to how we are today, we can see that the trend is very, very clearly that we're living longer, and the population as a whole is getting older. And the thing that we know with that is that as along with that aging, there's also an increase in the prevalence of chronic diseases, things like high blood pressure, congestive heart failure, chronic obstructive pulmonary disease, and others. And these are particularly true. They're also increasing in the elderly. And with these, this increase in the frequency of these chronic diseases, people tend to have more acute exacerbations of those. And that oftentimes requires hospitalization and an increasing utilization of healthcare services, and that increases and contributes to increases in healthcare spending. So this is a trend. You know, these data are from the U.S., but it's certainly true here. It's true really across the world.
So what we've been doing up until now in reaction to this demographic change is basically, and these are OECD data, to recruit more people in healthcare. So if you're on the right side, that's a positive net recruitment, and the blue is the public healthcare sector. So only countries with some recent difficulties are decreasing their staff, but the rest of us up high, we have been recruiting all the people that we could reasonably find in order to tackle the demographically related challenges with the chronic diseases that are increasing along with that demographic change. And that also affects money, certainly, on a national level, because this is not small money. This is a slide I got from Michael Porter that is showing the healthcare spending in relation to the GDP in different countries that are more or less similar to Sweden. And what we see is that the graph, the curves are diverging, meaning that a larger and larger portion of the spending in society is directed towards healthcare. And that's not sustainable over time, because I think we need some other things in society as well, like schools and roads and stuff. So healthcare cannot eat up too much of society's money, even though we who are in healthcare pretty much enjoy this. But it's not sustainable, and we know that.
And so, in addition to these trends of, you know, the increasing demand for healthcare services and the rising cost of healthcare services, the other big challenge is that healthcare is just really complicated. And it's complicated for a few different reasons. One of the reasons I think has to do with the historical trend towards specialization in medicine. That is a trend that started more than 100 years ago, and has resulted in in many very, very good things. Notably the whole sort of medical research industry, really, focused around academia and all of the disease and diagnosis-oriented specialties that have contributed enormously to our increasing knowledge and technology and abilities to diagnose and treat disease. But on the other hand, that same kind of organization around the specialties has also been adopted in the care delivery system as well. So if you go to a hospital or any healthcare system, you have a very similar kind of organization of departments and care delivery systems as you would find as if you went to a university or a medical school, and you have the same departments basically. And so when you take that model and put it into a healthcare context, it creates these kind of vertically integrated silos of care delivery. And that is what has led to a lot of the fragmentation, the structural fragmentation in how care is delivered, but also, interestingly, around how data is gathered, how finance works, how we measure quality and performance. It's all equally fragmented. And what that creates is an enormous difficulty to really understand what's happening at a healthcare system level, because the systems for understanding that and the data are just not organized to understand the whole thing. It's everything is built around these individual silos, and getting from that kind of silo data to a systems view is not trivial. And that's, I think, at the very core of what we've been trying to address and deal with in our work together. This is just one quick example. If you look at this kind of spaghetti diagram of all the different possible pathways that patients with acute problems can take through the system in Region Halland in order to get care, and you can see it's complicated. I mean, it's not impossible to navigate, and people do, but the point is that things are not easy and simple.
And that's the case also for the patient. If you look at the healthcare system, it's intrinsically complicated in itself. The biological entity, the human being, is a complex adaptive system, taken care of by a other complex adaptive system, the healthcare system. But the ecosystem of healthcare is increasing in complexity around the patient. So what we used to appreciate as the monopoly of healthcare, Region Halland, Västra Götaland, or whatever, is now not competing, but working in an ecosystem with a number of other actors entering the stage, which is dramatically increasing the complexity around the patient. And this also drives healthcare into becoming an information problem. How do we deal with all the information generated or gathered and stored in all those different silos, because they are also silos to some degree. And from the patient's perspective, all these entities are part of his or her medical care, if you ask the patient. But what they also know, or we, the patients, is that information is important. Information about their healthcare condition. And they know that physicians and others need that information in order to make good decisions together with the patients around their healthcare or unhealthy condition. So if you ask them, they want us to use their information or their data. They expect us to do that, primarily for research, but also for healthcare development. Not so much for other purposes, but for those purposes, they either think that we're already doing it or they think that we should do it. So that's the public opinion and that we need to be aware of. But we also need to guard the integrity of these people. If we don't do that, that trust that they give us will not be maintained. So we need to be aware of the fact that this is super sensitive data. The inner core of people's feelings and experiences and diseases and everything might be in there. So that's something you have to take into account and definitely respect. Because if that trust is lost, we cannot work and we cannot provide good healthcare simply. So the governments are well aware of this balance between integrity and the need for structured data. Everyone is craving for structured data these days. But we have a number of healthcare-related regulations to take into account, which is super important. But at the same time, we have to be aware of the fact that information blockage is a real threat to the patient health. So there's a balance that we have to navigate upon. But as I said, the governments are well aware of this. So they are currently looking over the regulations and seeing how they can be reinterpreted or rewritten, but that's a lengthy process. The Swedish government is doing that, but in the Nordics, I would say that Finland is leading the way. They ratified a set of new laws on this subject, and hopefully we can learn from Finland from this aspect. They are successful in guarding integrity and at the same time making use of the information to leverage care and research and care development. So I think things are moving forward, but regulations are difficult to adopt and renew.
So the question that we kind of end up with is this one of, how can we really fundamentally improve healthcare? How can we make radical changes? When we compare ourselves to other industries where we've seen, over the last decades, really enormous improvements in productivity and quality and cost effectiveness, healthcare has kind of been stubbornly not keeping up with that. And I think that we haven't seen quite the same degree of kind of global transformation and efficiency in healthcare delivery. And I think everybody has a similar goal. We all want to improve outcomes. We want lower cost. And I think that there's sort of two big areas where this is where there are big needs, I think, for and that we want to try to help to serve. And I think one is with healthcare policy and decision makers who are tasked with improving healthcare systems. And the ways that they can do that is typically by establishing new structures and new processes for care delivery. And the question is really there about, how do you make decisions about that? And the other area is at the care delivery level. Care providers, all the time have to make decisions about diagnostic and treatment decisions for their individual patients, and they do that. We do that based on our training and our experience and our judgment, but there are limitations there, and the way, and the whole piece about the fragmentation and the complexity of the system, I think, is one of the big challenges that confront both system leaders and decision makers, but also care providers. And so the way we think to enable and support both system leaders and care providers to be able to make better decisions in the work that they do and make healthcare better and deliver better healthcare is by having better insights and being able to use the enormous amounts of information and data that we have to have better insights. And that's really I think our sort of focus and purpose. And so with that kind of challenge in mind, we have embarked on this collaboration to really try to figure out how can we push the frontier of what we're calling data-driven healthcare. And what we want to share with you now is to talk a little bit about some of the data models that we have developed to try to better leverage the existing data that we have, to talk about care delivery capacity and cost accounting, not the most exciting topics, but nonetheless really important ones. And then to talk a bit more about these two concepts of data-driven management and personalized precision medicine.
Okay, so when we started out this journey, we realized that, well, we have all this data stored in different silos, different types of data, different formats, but all in all, a lot of data. And what the data is not worth very much if you don't make this journey. So you need to transform the data into information, first of all. But some stop there and think that that's good. We have all this information from the data. But the value does not appear until you create insights based on this information. So the data storage and the data structure and the data handling is just only the first phase. And the really fun part for all us appliers who are trying to understand how we create better health through better providing healthcare systems is here, when we can create change based on these insights. But you have to make that a bit sometimes tough journey first. And then when you have made the change, obviously you can do the follow-up based on the same data that you started with. So it's actually a loop. But that's a journey you have to do if you want to reach precision medicine. We come from a situation where now we're in precision medicine. We treat groups of patients. We actually, to be honest, don't treat very often your individual particular disease. We treat the disease as we usually do when it appears in a human. So we're going from imprecision medicine with the help of DNA sequencing and all that into precision medicine. But what we also want to do is to go from imprecision management to precision management. And that's also, to be honest, we did not have, if you don't have the data to create information to base insights upon, you cannot have fact-based decision making. So we're on that journey now, and we will show you going forward a number of examples what you can do when you start reaching this part of the information value chain, so to speak.
So when we first started working together on this collaboration, it was really focused on trying to what the main goals were. We're trying to come up with new tools for being able to better understand and improve acute care delivery, acute and unscheduled care delivery, and in order to do that, we realized, as Markus was saying, that we had kind of an imprecise view of the whole system. And if we wanted to have a way of trying to think about, and come up with better ways of delivering care at a system level, we need to get our arms around all of the data in the system. And as we talked about before, the data in its native form just is not set up to be able to do that very easily. And that's not just true here, it's true in the US, it's true really everywhere that I've ever been and seen. And so what we needed to do was to link together not just the clinical data, the data about the inpatient admissions and outpatient visits and emergency department visits, but also if we wanted to really understand how the whole system worked, we need to also think about resource data, right? The resources for delivering care, and that includes the facilities, it includes the providers of care, and we also needed to take into account cost, because that's one of the things that although we don't always talk about that, and we're not trying to we're not trying to generate profit, but at the same time, if the care delivery system is not financially sound, it's difficult to do the kinds of things that you want to do around improving access and quality and all the other things that we want to do. So we have to think about all of these things. And the problem is that in most healthcare systems, all of these different domains of data tend to be organized in different systems and used and maintained by different personnel groups. So the clinicians tend to work with clinical data. The finance people and administration, they work with the cost data. And then, managers and HR people tend to deal with all the resource data. And so when they come together to talk to each other, they have their own data sets that are not typically linked together, and it sometimes feels like we're all speaking different languages. And it's hard to understand each other, and it's hard to make good decisions about how to change the system when the different parties that are involved in that decision-making process have fundamentally different views of the world and the work that they're doing. And so what we were able to do was to link all of this data together in a single system in a way that allowed for us to be able to do some of the analytics that we're talking about here. So here's some of the data domains that are contained in the platform. And this platform, the acronym SHARP was a way of referring to this, which means the Strategic Healthcare Analysis and Research Platform. And so in this, we have data on all of the pre-hospital ambulance visits or calls, the emergency department visits, inpatient admissions, outpatient specialty clinic visits, primary care, and also social care, which is delivered by the municipalities. So then we have all of the clinical data, which includes all the diagnostics, the labs, imaging data, EKGs, also the medications that are given, including prescriptions that are written for outpatient use, as well as what's picked up at the pharmacy. Then we have anonymized data about the patients, their age and gender and other factors, but not identifying information like their actual personal number or their address or their name. We have also anonymized information about providers, and then we have capacity information as well as cost information. So all of these different domains represent different parts of the system and how it functions, and we've been able to link all of this together. In the future, there's other things that we're in the process of adding, including patient-reported outcome measures, sensor data. There's some work that we'll talk about with natural language programming or processing for developing structured data out of that. And then also genomics data is on the horizon for being able to include. So I want to talk just for a moment here about cost and cost accounting. And just as a disclaimer, I don't have an accounting background. We are clinicians, but we had some fantastic help both from the regional financial controllers as well as some of our colleagues at Harvard Business School from the value-based healthcare unit, where they have actually a lot of experience around healthcare cost accounting. And what we what we realized is that it was, if we really wanted to understand value and to be able to quantify that, we had to have a way of figuring out the cost of what the actual cost of care delivery was at a patient encounter level. And the reason why that's important is because if you're trying to, the way that most healthcare finance systems work is that they allocate cost to departments and to service lines. And so, you know everything about how much, the Department of Cardiology spent on personnel and facilities and equipment and supplies. But if the question is, well, how much did we spend on congestive heart failure last year? Not just in the Department of Cardiology, but across the whole healthcare system, nobody has a clue. Really hard to say. You can figure it out, but it's not something that's easily gettable. And that kind of a question, right, from a population health management perspective is really important. And so we came up with a lot of help from our team with methodologies for being able to allocate all of the system level costs down to the level of the individual patient encounters. And we call that PEC, or patient encounter costing. And it's a simplified version of a kind of an industry standard approach, time-driven activity-based costing. I think one of the key things that is unique about this is that we also, unlike most of the patient encounter costing systems that are out there, we take account for the unused capacity in the system, which is important if you're not operating at 100% capacity and you want to be able to compare and do cost trending from one year to the next. So we are able to account for that in the system, and we think have a much more accurate way of describing what the actual costs of care delivery are. And so as an example here, you can see this is a representation of the entire healthcare budget for 1 year in Region Halland. And what we've done here, having done this transformation of the costs, can now look at how much is being spent across the entire system on different things. Here it's at a very high level. We can see it's broken down by the major kind of diagnostic categories. But it does, and we can drill down and to go into much more detail and say, for example, how much did we spend on congestive heart failure as a percentage of the whole system? And we're able to do that relatively easily. But it's a way that you can now have, by having that granular data, you can look at different populations and healthcare processes with relative ease across the system. So the overall, now with this whole data system in place, with the different types of data linked from all these areas that we talked about, we have the ability to do analyses and analytics in a bunch of different categories, both in the this area of data-driven management, as well as in the area of what we're calling personalized precision medicine. So on the data-driven management side, I think two of the big areas that we're able to address, or questions we're able to address, is number one, identifying and quantifying opportunities. As I said before, one of the big challenges that healthcare system leaders and decision makers face is that they have to make decisions regularly about which new structures and processes are you going to implement. There's no shortage of good ideas about how to improve healthcare. The challenge is how to prioritize those and how to know where to focus. And by doing variability analysis, we can look at individual populations or healthcare processes and see how much variability is there in outcomes, in utilization, or in cost, and use that quantification of variability as a way to see where the biggest opportunities for improvement are. Then, when we want to think about which types of interventions do we want to implement, we have a way that we'll talk about here in just a moment, that we can analyze and evaluate specific new initiatives and quantify the likely impact that would have on both outcomes and on cost, and then use that information as a way to inform decision making. On the care delivery side, we'll show you some examples here in just a moment of how we can use this data approach to be able to monitor implementation of evidence-based guidelines at the population level, and then use that for optimizing care for individual patients. And then lastly, and I think probably of most interesting for this audience, is the way that we're using this to support machine learning and predictive modeling to identify healthcare outcomes of interest, and then to use that information to inform care. You want to take this one?
Sure. We do it not randomly, obviously. When we catch an idea from somewhere in the organization, or the politicians or the management level, we want to understand more about that question. We will come back to mental health, for example. But so if a politician comes to me and says, mental health, how is that working in Halland? Is it increasing? Where is it increasing? How does it manifest itself, etc.? Then we do it in a stratified and planned manner. So we identify the problem, and then we identify the cohort, because you always need to understand who you are studying, and then identify metrics of interest, and then we do iterative exploratory analytics just to understand the demographics of that population before we start calculating future impact of different ways forward. So we have a playbook on how to do this procedure.
And so then once we've done this kind of an analysis on many different proposed new initiatives, right, where we can quantify now what the likely impact is going to be that would come from a new initiative, both on outcomes and on cost, we can then present that information to decision makers in the system and allow them to prioritize different initiatives. You know, because typically in any organization, you know, you have the resources and the capacity, say, to do 5 things, you know, this coming year. We can't do 100 things, right? And you have to pick which 5 things do you want to do. There's 100 ideas, and everybody thinks that their idea is the best idea, but the reality is that you have to prioritize. And this is a way that we can quantify the impacts in a way that can assist decision makers in their work.
And this is one example where we identified. So one of our cardiologists had a gut feeling that we are not doing an optimal job for the atrial fibrillation patients with a arrhythmia disease in the heart. If you have this disease, you have an increased risk of stroke, which is something very bad. And we need to understand on a systems level how good a job are we doing in order to protect these patients from unnecessary risk of stroke. And you can do this and say, we're pretty good, or we're very good, or you can put numbers on it and say exactly how good you are. And then you can calculate backwards and say, if we invest in interventions towards these patients and treat them a little better, certainly they will fare better and have fewer strokes, but the healthcare system at the same time will lower costs due to the strokes that are being prevented. So this is a very gratifying way to look at a problem, both from the quality perspective and the humane perspective at the same time. Just one example.
And I think it's important to note that, to our knowledge, this is the first time that anyone has been able to do this at a whole population level before, where we were able to identify the entire population of patients with atrial fibrillation and figure out exactly, you know, how many of those people there are, how many of them have an indication for anticoagulation, how many of them actually got it, right? I think this is really new and very powerful.
And also, we were interested in directing more resources towards the high utilizers, the patients who need a lot of care. And it's not obvious on a systems level how to find those people. And we had an initiative where we tried to think of indicators of high care utilization and direct more resources towards those needing individuals. But it turned out to be wrong, because when we followed the initiative, there was no effect on care utilization. So then we went back and we did our homework and our maths, and we realized that we had been directing our resources to the wrong patients. So we redirected our resources to a new group of patients, or partly a new group of patients, and all of a sudden we could see effects on the number of patients showing up in the emergency department with these diseases. So fact-based decision making has the potential to really affect the resource utilization on a systems level. We are also well aware, as in any healthcare system, that you become a high healthcare consumer when you're closing in on the end of life. So what you don't want to be doing the last weeks in your life is to go back and forth between the hospital, the home, and other places in the healthcare system. But the difficulty is to understand when you are approaching the end of life. But if you have your data in place, you can actually see the pattern and meet those patients' need up front, because no one wants them traveling around the healthcare system. So you can redirect your resources towards the patient that you know will be the high utilizers before they become the high utilizers. We are now turning from like more conventional math to what we are working with currently and ahead. And part of that is applied machine learning and using neural networks for pattern recognition and predictions. And this is a slide from Eric Topol, a thought leader in the field. And what he summarizes here is that most of the research and clinical applications at the moment in the field of AI in medicine is in imaging and diagnostics. But there is a huge potential for understanding the whole system as well, the medical system and the care for individuals. But we don't see it happening just yet in CE marked or FDA approved applications. So we are behind some other industries in the field of AI, but we are making progress.
Jumping back to our organization back in Boston, we're also doing a lot of work around machine learning and developing AI methodologies and tools. And a lot of that work is organized through an organization called the Center for Clinical Data Science at Mass General Hospital and Brigham and Women's Hospital. And in that center, there are teams of data scientists and software engineers, data engineers, infrastructure engineers that are able to have access to the whole set of patient data from across the whole partner system, which includes millions of patients. They have an industry relationship with NVIDIA and have developed an enormous GPU computing cluster to create the kind of computing power to be able to train and validate these types of AI models, and also work very closely in a tight collaboration with clinicians to develop new models and programs. Two examples that are in development right now and about to start testing this summer. One is around the problem of acute strokes. So when patients come in with acute strokes, one of the big questions is, are we able to treat them with thrombolytic therapy? And the thinking and decision making around that has to do both with the length of time from how long ago the stroke started, but also the size of the stroke and other characteristics. And so we quickly get those patients to imaging and generate an enormous amount of imaging data that the radiologists have to interpret. And the problem with that is time. And so the CCDS has come up with a whole suite of algorithms actually that are able within seconds to go through all of that data and to pinpoint the potential areas of concern so that the radiologist can just go right to the area and be supported in their decision making. Similarly, with spinal trauma patients, I work in the emergency department. We get motor vehicle accident and other patients with potential spinal cord injuries. And again, the question is, when we have someone with a possible fracture, we run them through the scanner and we generate enormous amounts of data that take a long time for the radiologist to go through. And this is a way of really accelerating that kind of work. And lastly, I think before we take our break, I just wanted to say that the work that we've described with developing the Sharp platform and the kinds of analytics that we're using here in Region Halland, we're now in the process of implementing those in Boston through an initiative. It's an internal incubator program called the Brigham Clinical. What was it? The Clinical Redesign and Incubator program. I can't. But so we're in the process of developing this and hope to have that up and running. And we're excited about that because that will then now give us an opportunity to be able to start doing benchmarking and other types of work with distributed analytics and things that we're going to talk with you about in a moment. Okay.
Some questions.
Yep.
Okay, can you hear me? Yes. Okay, we should open up for some questions. And I think I will start. I'm thinking of this process you showed in the beginning from data to follow-up. Where in this, do Halland cover the whole process today, or where do you stand?
Well, I think nobody does, because many healthcare systems are stuck in the first phase, having a lot of data but not using them very much. But a few systems around the world, the forward-leaning ones, are in the information part. So there is more and more information being used. But then when you start applying trained algorithms, machine learning models, etc., you can start creating insights based on this information. That's where the fun part starts, and that's where after the pause we will reveal some really exciting things to you. So that's that's where Halland is at the moment, actually creating new insights and testing some new initiative based on these insights. We have a continuous follow-up, certainly, and all healthcare systems do, and we can see some effects. I will show you some overall effects after the pause on cost reductions for the whole for the system as a whole. So I think we are a little bit in all of the boxes.
Okay. Yes, and do we have any questions in the audience? Yes.
Hello. Actually, I have a question in two folds. The first one is about data privacy. Since it's a project between Boston and Sweden, I'm wondering what is the guarantee in terms of having the user patient data maintained, secured, and safe. And the second one, without getting too much into details, is more about why using deep learning for this this endeavor if it's not about radiotherapy or medical image data.
So I can answer the first one.
Yeah.
It's good to have the legal people with you along the way, and in the collaboration, everything is in Halland. So the region is doing things itself together with some people from the local university, but with guidance from the collaborators. So data privacy is super important, as I started saying, and you have to take care of that in every step of the way. And there are limitations, certainly. The other question was...
I think the other question was about deep learning.
Why using actually deep learning if machine learning would actually do the job for simple medical data?
I can't hear really the question, sorry.
So machine learning algorithm could do the work if it's not about the image data that are used in radiology.
Oh, who does the work?
I'm saying, why going to deep learning if simple algorithm in machine learning would actually perform pretty well and accurately?
So what we are doing with... we will come back to the examples where we apply neural networks and some deep learning, and maybe it will clarify then who is doing what. Could that be an option?
Yeah, okay. Do we have any more questions? Yes, here. Do we have a microphone? Yes.
So when it comes to the data privacy, it is very sensitive data to be shared. So I often see that in healthcare, using cloud services is considered almost kind of big no-no, because you don't really know where that data is and then what kind of protection that you're getting. And the general UMass has a lot of cluster computing power, but going forward, do you think it's sustainable that you will always have to utilize local resources, or is there some missing thing in cloud computing that you think that going forward healthcare might actually adopt cloud computing to sort of leverage on the compute power that you will not sustain for long term in the future?
So while checking the microphone there, we will present to you in a few minutes one or two ways of addressing that exact issue. Today, few healthcare systems are prepared to store data outside their premises, and that's the case also here. We don't spread the data anywhere. But in order to scale analytics and scale data volumes, there are other ways to approach that problem, and it's about distributed analytics and federated learning, and we'll come back to that in a second.
Okay, maybe we should continue the presentation, and then we have more time for questions in the end.
Okay.
Yes.
Sounds good. Okay, I'll take this. I think my headset ran out of juice. Okay, so what we want to talk about now is to turn to to the results.
Yeah, and it's the results are related to system efficiency and productivity. We will show you some examples there, but we're also more and more introduced and also interested in real-world evidence studies, like the academic part of utilizing the patient trajectories and fact-based learning, and then applied AI in predictive modeling. That's something that we spend a lot of time on right now, and that will turn back to your question in a while. So, yeah. And starting top down, during the years that we've been working together with Halmstad University and Kaiser, and also the Boston team, the number of hospital beds in Halland has been reduced. That's pretty common for different reasons, but what we have seen is that we've been able to reduce in a fact-based manner, planned manner, the number of in-hospital beds without increasing the occupancy. So we now have even a lower occupancy level than we had at the time where the number of hospital beds were 20% more, and that's 2015 and 2014. And the length of stay has decreased dramatically over the same period of time. So isn't it dangerous? Some people ask, well, you have to keep track of the quality at the same time. So readmission rates, mortality after hospital stay, etc. All those indicators need to be tracked along with the production and the resources and the economy. And that's why it's so important that you don't analyze data in your different administrative silos. So the financial department can't look at the financial data only, the HR department cannot look at the HR data only, and the clinicians cannot look at the clinical data only, because they all go together. And for the managers, the synthesis of all that is the only thing that counts. So, but working thoroughly and systematically, we have been able to increase productivity and efficiency, which is two different things. That's efficiency is when you take more into account the outcome of the patient, how well do they fare, how long do they live, etc. By significant amounts. You can go back to this slide later. One example of what kind of insights we can create now is on congestive heart failure. This is a large patient group, and it's a good model because they have so diverse care needs. It's all the way from a pill a day to heart transplant. And it's all the way from primary care, ambulatory care, and intensive care. They are all over the place. And if you want to do a better job as a healthcare system for that large patient group, you have to understand how they move all across the system and what their needs are. So we were able to do that, and this is actually preliminary data from a study that will be published sooner or later, where we looked at our 6,000 congestive heart failure patients, and we're interested in whether or not they were compliant to guidelines or not. And if they were compliant in guidelines, how did that matter to them and to the healthcare system? And what we could see is, I think that's on the next slide, yes, is that if you are a compliant congestive heart failure patient, which means that you have your prescriptions in order and you take your medicine, or at least you go and buy them, compared to if you're not a compliant congestive heart failure patient, there is a dramatic difference in total cost, annual cost for that patient. And some people have a gut feeling reaction that, oh, well, you just treat them more and they get better, and the treatment itself is expensive, and so being aggressive in guidelines compliance will increase cost for healthcare systems. But that it turned out to be the opposite. Like investing in patients to get them to be healthier actually reduce costs in a significant way, 23% on an annual basis per patient. So that was that's kind of an example of an analysis that you can do when you have done your homework on the data side. And then you can put on those analysis more advanced optimization algorithms to see where's the optimum. Exactly how much should we invest to reduce costs and improve outcome the most for this particular patient group. So you can use optimization analytics to find the sweet spot of how to take care of large patient groups across the system in order to provide best health to the lowest cost. So when we introduce these things to our clinicians and sometimes to the financial department, whoever, and say we want to do advanced analytics to understand more, to go from information to insight, this is sometimes the reaction we get. So AI in itself is just a blob to some people, and some people think it's robots, and some people think it's driving cars, and some people relate to artificial general intelligence, which is a completely different story, as you know. So you have to do a lot of introductory work before you get to the insight creations. Yeah. But what's important to take into account when you train models on healthcare data is to not introduce the human biases that we all carry with us. And those are the cognitive biases. You know them all. They're not new. But I just want to show this because if you introduce biases into models that are being duplicated and used for thousands of patients going ahead, you spread biases in ways that are exponential. So you can do really large harm if you don't think thoroughly through your training models. Having said that, this is an example on how we use big data analytics in order to understand one of our major issues in society today, and that's mental health. Lots of people say we have a huge mental health problem in Sweden and elsewhere in the world, and well, yes, we might do that, but what exactly is it about, and what should we do about it? And there we are loaded by hundreds of ideas. You should invest in this or that and whatever. But to really know that we invest taxpayers' money in the best way to actually help those at risk of aggravating mental health issues, you do again need to do your homework. And this is just an example. Two friends at the Halmstad Högskola helped us to understand the group of mental health with mental health issues in Halland and say, can we understand more who will fare not so well? Who will have the bad healthcare consumption trajectory? Because that's something we think is when you end up in psychiatry, that's like very late, and you want to understand what happened before with those patients so that you can intervene before there's a catastrophe. And the worst end here is suicide. So this is real tough stuff. And it's important to direct our interventions towards the patients and the individuals who really need it and who really benefit from it, and not some smeared out interventions that will make no use. Another example is a research paper, actually, and it's not for pre-review only anymore, because it's closing in on publications, but that's where we used different models. You might be familiar with some of them: support vector machines, random forests, and k-nearest neighbors, and a few others, to understand who, after having been sent home from the emergency department, will die. So that's the kind of tough questions we live with every day in healthcare. And Philip is an emergency physician. That's the kind of decision he makes every day, at least half an hour. How many patients do you treat per hour? I don't know. So this is one of the usual decisions: admit or not in the emergency department. And when you don't admit, you need to, as a physician, feel secure that that patient you discharge from the ED will fare well, because if not, you should maybe admit the patient. And what we see here is just a very not easily digestible slide, but there are areas on the curve, the accuracies of this model, that are way beyond the clinical capacity of a human black box. So this is how we work with clinical decision support systems. And of course, all these need to be validated according to the scientific playbook of medical research. But having done that tough, long journey with integrity issues, with legislation, with ethics approvals, IRBs, etc., you can eventually integrate those into the electronic health records to guide and make care more secure.
So what's really interesting about this from an emergency medicine clinician perspective is that, first of all, just the fact that you can get a prediction or a risk level for death within 30 days for someone that you're sending out. That in and of itself is really interesting. But when you look at it more closely, these patients, you can sort of break them out into two groups. One in which death would be expected because of the nature of their underlying illness. People with end-stage cancer. We're actually the emergency department for the Dana-Farber Cancer Institute, so we see a lot of patients with end-stage cancer. But the other bucket are people in whom that death would be unexpected. And I think both of these are interesting for different reasons. The ones who have an expected mortality, right, that's an opportunity to make sure that those patients are enrolled in palliative care, if they're not already. But for the other group, it gives us a unique opportunity to reconsider and to think about, is there something maybe that we missed or something that we overlooked? So I think from a patient safety perspective and a quality of care perspective, this kind of machine learning based prediction is an enormous step forward, I think, in terms of our ability to optimize care in the emergency department.
And this is just another model that we trained. We have the opportunity to have 3 hospitals in Halland, so we usually train the model on one hospital and we test it on the other, and then we do the vice versa. This is just an example of what you can achieve if you try to understand what happens or what will happen after you discharge a patient from a ward. So you say to the patient, hey, your inpatient stay is over, you're going home today, and you will have a follow-up in primary care maybe. But you want to make sure that you're discharging the right patient at the right time. And also for that, predictive modeling is of great value. And what we can see here is that if you integrate the correct variables into the model, the accuracy can be very, very good. Regarding readmission within 30 days, or again, death within 30 days after having been discharged from the hospital. And why is this important? Well, it's obvious to most of us, but from a management perspective, it's also important, because then we can direct our planning to the specific patients with high risk of readmission or death, for that matter. Death is can be in a patient on palliative care here. So death is not always unexpected, or even not always unwanted. So you still have to evaluate the information, but you can get the alert that you think you need to think another time on this patient. Okay. We're going forward with broader collaborations now. So this is an upcoming initiative. It's called Lund, where we work closer with, obviously, Lund in this case, where we in Halland, we have one work package on understanding trajectories around cardiology patients, but then Malmö has one on what happens within the emergency department and how can we triage patients better so that we focus on the ones with time-sensitive conditions rapidly. So that's ongoing work, and an application has been sent in. So that's how we now start to try to combine different aspects around a common issue. The third one is on applying neural networks on genetic data. So when you have sequenced the DNAs of a population, you can understand who will not fare well in different perspective. Yes. We are also interested in not building larger hospitals, or rather, we cannot do that in Sweden because there are no more resources. Hospitals are the most expensive ways of delivering care. And if we can do the same thing in other settings, like the patient's home, we would be in a better place. And definitely the patient would be in a better place, because the hospital is not like a vacation. It's a harsh milieu. So if we can have the patient feel safe and also do what we need to do with the patient without moving him or her around in the physical system, a lot will be gained. And that's one of the initiatives at Halmstad University at the moment, where we collaborate together with municipalities around intelligent homes for primarily elderly people with chronic or multiple conditions. And in that project, you need to take care of not only the data or the analytics, but also the ethics and the legal issues, and they're all the colors of the same initiative or problem, and the financial part as well. But it's very exciting working across knowledge domains to move these things forward.
So that was a kind of an overview of some of the results and the outputs of the work that we've been working on together up till now. And what we want to talk with you a little bit about now is to focus a little bit more on some of the next steps, the types of problems and strategies and tools that we're working on trying to address and solve. And these include strategies for trying to amass larger data sets. And I think several of the questions before were kind of touching on that thorny problem, you know, in the kinds of regulatory environments that we have. How can we combine data sets in a way that is compliant and allows us to analyze and use that data but still maintain the privacy and so on? So that's one issue. Distributed analytics is a part of that solution, we think. And then also thinking about are there other purposes for this types of work and research that are important to explore.
So one initiative that is, this is actually the first time it's presented, is a U.S. initiative driven by Sendel Muller-Nathan, who's a professor at the University of Chicago, and also Siad Obermeyer, who is assistant professor at Berkeley. And they are creating this Nightingale initiative with the support of Schmidt Futures, where they aim at connecting the best computer scientists with the best statisticians, with the best clinicians, with the best data, wherever they turn out to be around the world. And that's because when you gather the right people around the right issue, then magic happens. And I've seen it happen where you combine all these competencies, and sometimes you're very lucky to come up with completely new insights. They are trying to systemize that on a global scale. It will be launched next year, so you might hear about it then. But they are pushing into this the new field of computational medicine. So that's one way of addressing the scaling issue and those kinds of needs.
And I think one of the key features about this is that it's the concept behind this is about bringing data together. So it's having data that is sort of linked, but in order to do that, you have to anonymize the data, right? So that's kind of one strategy for how to bring together disparate data sets is through anonymization and then linking them either on a cloud server or in some other way. The other approach or one different approach that we are trying to explore and work to develop is to not link the data and to not anonymize them, and to allow the provider organizations, the healthcare systems who generate the data, to keep their own data and keep it safe and secure behind their own firewalls, but to have a suite of technologies and approaches that allow us to do distributed analytics. And what we mean by that is there's a number of examples and methodologies for how to do this, and we can talk about them in more detail. But basically, the concept here is around putting the analytics out to the provider organizations and having those be run, and then having the aggregated results come back. This is desirable for provider organizations because they don't have to worry about somebody else accessing their data and sort of possible data breaches. They get access to international benchmarking. They can benchmark with other organizations, and they can also potentially have more accurate AI algorithms that they can use within their own system in some of the ways that we've shown and demonstrated in Region Halland. So the question here now is around this these distributed analytics, and how does that work? The basic idea, Markus came upon this idea of this notion of base jumping, with the notion being, I think it was initially a baseball analogy, right? That the idea would be that you can go around, if you think about the different nodes on the network as being different bases, and that you can reach out and essentially touch each one of those in the analytic process. So you have a researcher or someone who wants to make a query who is able to generate that through this trusted network, and the analytics are, or the analytic query is broken down into a way that can be sent out to each of the nodes. The query would be run behind, in that system, behind its firewall. The aggregated results are sent back and then recombined in order to get a result which is essentially the same as if the data had been linked initially. And so the advantages of this are that only the aggregated results are being shared. The patient level data is not being shared with anybody outside of the system. And we think that this approach will be one that will satisfy the requirements of systems like, the regulatory environments like GDPR. One way that this could work, so if we think about the development of an AI predictive model, the first step is identifying a population of patients that have an outcome of interest that we're looking to predict. We take a randomly selected sample of that population to do the training on. And for some very common conditions or common outcomes, we don't necessarily need to have an enormous data set in order to carry this out. But for things that are less common, having a much larger data set that could only be put together by having multiple different systems working together in this way gives us the ability to do this in more and more different cases. But the other point here is that we also want to think about the contextual data of the system that the data is coming from. So depending on which healthcare system you're from, that data, that contextual data, could be relevant and valuable, and maybe even add more accuracy to the resulting algorithm. So then once you've trained the model, then validating it in another randomly selected sample from the overall network would allow us to then have an algorithm that we could go out and could be implemented. But the idea then with that, when the algorithm is implemented in each one of the different nodes, it can continuously be updated going forward as new events happen, and that will, and then that information can also be fed back and inform the refinement of the algorithms in all of the different nodes. So there's a benefit to being a part of a network like this because of the continuous development and improvement in the algorithms.
And this is a model that we think is more doable before healthcare systems are being prepared to send the data to cloud solutions, because that's certainly another way of going forward, where you can expand processing power according to the task at hand, etc. But we don't see, when I speak with colleagues around the Nordics, few of them actually are prepared today and in the near future to make that step. So this is another way, and this is something that we are developing or together with the Kaiser team at Halmstad University. There are different ways of doing distributed analytics, but the main idea is to respect privacy, basically, and to not risk sensitive data being used to be used in the wrong way. And you probably need a hub or a node somewhere where you have not really the metadata, but at least the model, the basic script, and before you send it in and out to different healthcare systems. And we are in contact with a handful of great healthcare systems at the moment who says, yes, we need to work together, because data volume, specifically for conditions that are not so common, is a crucial issue in order to go from information to insight before you can act upon those conditions in different ways. Next slide, please. So you can either, there are two basic notions. Either you're the node and you send the model in and out from the different healthcare systems, or you instruct it to touch all the bases, the healthcare systems, before it comes back. And having done that, it's been exposed to larger data sets, but the data sets have not been merged or not been outside the privacy zone. So those are two different basic approaches that we are digging into at the moment. And we're not the first ones to think about this, certainly, but we are in a pretty good place. But there are publications on the subject that you can read and relate to. And as late as a few days ago, the Stanford team started talking on the scenes about federated learning, which is a little bit the same notion. That's where they send the models out to the specific individual's smartphones and do micro training before they bring the model back to the node. So that's and this is a macro version of federated learning. So, and very exciting future. It allows us to work together as healthcare systems on sensitive issues without jeopardizing sensitive data breaches.
So the last area that that's I think of interest, there's a great interest in industry in wanting to be able to access and use healthcare system data of the sort that we've generated, and to use it for appropriate purposes. I think the pharmaceutical industry develops new drugs that save lives and improve the quality of people's lives, and in order to do that better in a more cost-effective way, having access to real-world data to be able to do that can potentially both support and enhance the ability of pharma to develop new products, but also give healthcare systems more transparency into the cost effectiveness of new medications. So I think there's benefit for all the stakeholders in the healthcare ecosystem to be able to access this kind of very complete and robust data. So the road ahead, I think we've laid out here for you the work that we've been involved with and what we think are some of the successes and good results. And there's there's a lot more work to do, and we think the future looks very bright. Some of the things that we're focusing on in the near term going forward include, as Markus referenced, enabling the better and more integrated collaboration around data between the regions and the municipalities to really kind of make the whole picture of the patient's healthcare delivery more transparent and visible. We're also working actively to try to expand this international network of healthcare systems who are interested in trying to work on data-driven healthcare in this way. And we, as I mentioned here, we're developing this in Boston, and we hope in the very near future to be able to start working together around these distributed analytics between our two systems. We're in discussions with the NHS in England, who are very interested in collaborating on this, and there's also a number of other Swedish regions and others in the Nordics that are also looking to do this. And I think that our hope certainly is that there will that we'll be successful in being able to build this network, because I think the larger our circle of collaborators becomes, the more powerful what we're going to be able to do. Certainly, the ongoing work with the distributed analytics at Halmstad and at other places is a super important part of making this happen. There's a number of different technologies and approaches that are out there, and so part of what we're doing is testing and validating those. And then I think lastly, integrating natural language processing and taking advantage of that is another important technology, I think, for really being able to extract more data, kind of structured data, from what today is more, it just exists in text.
And if you want to get new ideas or complementary ideas, follow Eric Topol. Is a very thoughtful thought leader in this field. He's a clinician on the West Coast in the US. But he says that we are transitioning from what we call, or he calls, shallow medicine into deep medicine. What does he mean by shallow medicine? Well, it's basically episodic medicine for discrete decision and conditions, into a more holistic way of addressing the human creature's needs and demands, and using the whole healthcare system and social care system to address those holistic needs. And we are now in a phase in like human time where we can actually make this step, because I think we did all we could in the shallow medicine field. Episodic medicine, measuring productivity, fee-for-service system, very fragmented care, into a more holistic, more human-oriented care. And that's where all the clinicians want to go. That's where management want to go. It's not a conflict, but we're now where we can actually start doing this for real. So that's the end of our talk, actually, and both our batteries ran out during the talks. We've been probably talking a bit too much. Sorry for that. Hope you got something interesting out of it.
I just want to, I want to acknowledge, the fact that, Markus and I are standing up here on the stage and telling this story, but actually there is a very, very large team of people from both of our institutions who have been involved with this work, and none of this would have been possible without all of their contributions. And so I just, these are some of the faces. There's many more, but this work is a lot of fun. We really enjoy it, and I think the future of this is about expanding that collaboration. And so I think if any of you are interested and want to learn more about this, we're always interested and excited to talk to people who might want to get involved. And I just also want to thank my collaborator Markus. It's been so fantastic working together, and look forward to doing this for hopefully many years to come.
Likewise.
Yeah.